Welcome to this educational program. This module provides a general introduction to urinary stress incontinence. Other modules are available that review details on certain treatments for stress incontinence, as well as related topics, such as overactive bladder and urge incontinence. This presentation was written by specialists in the field and is independently produced. Urinary incontinence simply refers to any involuntary loss of urine. It does not by itself say anything about the cause of the problem. Normal urinary continence, or control, requires a relaxed, distensible bladder, a normal urethra or urine channel, and proper supporting structures beneath the bladder and urethra which make up what is called the pelvic floor. Any abnormality in any of these components may lead to incontinence of urine. It is important to recognize that incontinence is not a normal expected part of aging, nor is it a disease. It also comes in many forms and is not the same for everyone. Most importantly, please understand that many good treatments for incontinence exist, and in almost all cases, improvement and/or cure can be expected. The fact that you are viewing this program indicates that you are well on your way to achieving this goal. There are many types of urinary incontinence. Stress incontinence describes urine leakage associated with an increase in pressure in the abdomen, such as from coughing, sneezing, lifting, exercise, or sexual activity. Other types of urinary incontinence which you may have heard about include urge incontinence, leakage associated with a strong urge to urinate and caused by an overactive or spastic bladder muscle, mixed incontinence, a combination of both stress and urge incontinence, overflow incontinence, where the bladder fills up and spills over because it cannot empty normally, functional incontinence, where one is unable to get to the toilet in time because of a mobility problem, and total incontinence, which is continuous leakage, usually due to severe stress incontinence or some type of anatomical problem. To review, the most common types of incontinence are stress incontinence, which is a support problem and describes leakage with outside pressure on the bladder, urge incontinence, which is a bladder muscle problem and describes leakage associated with sudden urges to urinate, and mixed incontinence, which is a combination of both stress and urge incontinence. Urinary incontinence affects roughly 10 to 35% of adult women, translating to an estimated 13 million Americans, for example, suffering from the condition. The likelihood of incontinence increases with age, and in North American nursing homes, it is estimated that about 1/2 of the residents have some degree of urinary leakage. Urinary incontinence affects individuals in a number of ways. Most importantly, this condition directly leads to a lowered quality of life. Patients with this condition often avoid social situations where leakage may occur. They withdraw from their normal physical activities, such as golfing or walking, and they may avoid sexual relations for fear of losing urinary control. Urinary incontinence is also, unfortunately, a major reason why elderly people are placed into nursing homes. Urinary incontinence is a significant burden to our society. Direct costs related to incontinence include the costs of purchasing protective pads, payment to physicians for evaluating and treating incontinence, and the hospital costs related to treatment. Indirect expenses include loss of work following treatment or due to withdrawal from work for fear of leakage. Nursing home care for incontinent individuals is also very expensive. With all of this in mind, the primary goal of healthcare providers who treat this condition is to improve patients' quality of life. In treating incontinence, healthcare providers also aim to prevent health-related problems, prevent institutionalization for incontinence, and lessen related costs to the healthcare system and society as a whole. So why and how does stress incontinence occur? There are two main barriers to incontinence as mentioned earlier, the so-called pelvic floor supports and the urethra or urine channel. Weakness of either of these can result in urine leakage. Weakness of the pelvic floor muscles or supportive tissues is called pelvic floor relaxation. This may be something you were born with or programmed for, in other words congenital, or it may be caused by aging, childbirth, surgery, especially hysterectomy, obesity, constipation, or smoking. Damage to the pelvic floor during childbirth is the most common reason that women develop this problem. The normal urethra is made of spongy vascular tissue that collapses in on itself, and this also helps to prevent urinary leakage by creating a kind of seal. This tissue depends on estrogen, and unfortunately, it thins out after menopause or after surgery, such as a previous incontinence operation. Urinary stress incontinence is one of a variety of pelvic floor disorders, all of which are interrelated. Any given patient may present with any combination of urinary incontinence, fecal incontinence, and various types of pelvic prolapse, where the bladder or uterus, for example, drop down into the vagina. It is also important to understand that these disorders can interfere with normal sexual function. The evaluation of incontinence begins with an interview with your doctor, then a physical examination. The exam may be delayed if other testing is planned. Other possible testing may include such things as a pad test, an assessment of bladder emptying, urodynamics studies, and cystoscopy. In taking a detailed history, your doctor may ask you specific questions to elucidate urinary symptoms, symptoms of prolapse and bowel problems, blood in the urine, and pelvic pain. Any history of neurologic disease should also be noted, as should any surgical and obstetrical history. As always, a complete list of medications and allergies should be provided to your physician. Some doctors use questionnaires and diaries to formally assess bladder problems and incontinence, and you may be asked to fill out one or more of these. Questionnaires are validated assessment tools that doctors use to diagnose your condition, to quantify the severity and impact that it has, and to follow the results of treatment. These questionnaires are important research tools to evaluate the effects of treatment and provide a standardized way that doctors can communicate their results. Voiding and incontinence diaries are special journals that allow you to record details of your daily urinary habits, your fluid intake, and leakage episodes. These provide both you and your doctor a simple way to assess changes to your condition with time and the results of treatment. Most women with significant stress incontinence use some type of sanitary pad or diaper to protect their clothing from leakage. Your doctor will likely question you as to the type, strength, and number of pads used per day to gauge the severity of your condition. Doctors wanting a more accurate picture, and those doing research, may actually weigh the pads used in a 24-hour period. During the physical examination, your doctor will feel your abdomen to be sure that the bladder is not distended, and to assess scarring from previous surgery, for example. A pelvic exam is routinely done to assess estrogen status, to rule out other pelvic floor problems such as prolapse, and to demonstrate leakage. Rectal and neurological exams are also required in some cases. In certain situations, your physician may want to evaluate how well you empty your bladder. These include the presence of obstructive symptoms, a history of bladder infections, previous incontinence surgery, and in those with neurological disease, diabetes, and advanced age. This simple assessment can be done either with ultrasound or by introducing a small catheter or tube into the bladder temporarily. A more detailed assessment of bladder function is called a urodynamics study. This is a true test of bladder function, which provides multiple pieces of information for your doctor. It allows him or her to determine the stability of the bladder muscle and to measure the size, sensation, ability to stretch, and strength during urination. He or she can also determine if there is any obstruction to bladder emptying and can quantify the severity of incontinence. Finally, these tests are an excellent means of evaluating neurological conditions which affect bladder function. Urodynamic studies are quick outpatient procedures, which may or may not involve the assistance of X-ray. A small tube, or catheter, is placed into the bladder, and another is placed into the rectum to measure abdominal pressure. A separate module is available which describes this test in much more detail. Cystoscopy is another quick outpatient procedure, which is usually done under local anesthesia by putting some freezing jelly into the urethra. These tests are done to evaluate the lining of the bladder to rule out other bladder conditions, and to help with the examination of the pelvic floor. In summary, urinary incontinence is any leakage associated with increased pressure in the abdomen, such as coughing, laughing, exercise, etc. It is a very common problem and can be related to a number of different risk factors, especially childbirth. Evaluation of incontinence includes a focused medical interview and physical exam, and may also include questionnaires and diaries, a pad test, assessment of bladder emptying, urodynamic tests, and cystoscopy. Careful evaluation of incontinence is important, as this condition can be a very straightforward matter in some women, but a much more complex situation in others. Regardless, many excellent treatments for incontinence are available, and for almost every woman struggling with this problem, cure or improvement should be expected. Your doctor will help to determine the most appropriate treatment for you. These resources will help you find further information or support about your condition. This is just a sample of modern references discussing stress incontinence, available at your local medical library. We hope that this presentation has furthered your understanding of urinary stress incontinence. We wish you the best for the future, and thank you once again for viewing this educational program.